Good afternoon, everyone. Delighted to welcome everyone to a very special event and a special guest. For those of you who don't know me, I'm Chris Byrer. I'm the co-director of our CEPFAR, Center for AIDS Research here at Hopkins, and the CEPFAR is really delighted and honored to be hosting and welcoming Ambassador Deborah Birx. So for those of you who don't know, she is the director of our it's the Global AIDS Coordinator, but the office is the Office of the Global AIDS Coordinator. But that is a dual role. It means she is America's AIDS ambassador to the world, but she is also the special coordinator and a representative for health diplomacy. And that is really a very special role. Because as the AIDS ambassador and the representative in global health diplomacy, she really represents the face of American generosity and engagement in what is the largest bilateral commitment to a single disease in history. The U.S. commitment to PEPFAR is unprecedented. It's the largest in the world. We also are by statute a third of the Global Fund. And Ambassador Birx's job also is to oversee the U.S. contribution to the Global Fund to fight AIDS, TB, and malaria, which is the largest multilateral commitment in the history of global health. I think it often is underappreciated, especially now, that the U.S. is the essential donor in this global health space. And between PEPFAR and the Global Fund, Ambassador Birx has the really awesome responsibility and burden which she has carried out with extraordinary grace and integrity to really lead the U.S. effort on this front. So we are deeply grateful. We know that she's one of the busiest people in the free world for her to be here with us today. So welcome.
Thank you,
Debbie.
thank you,
It's great
thank you.
to have you here.
Thank you. What he didn't say is we go back about 25 years. I didn't realize he had just started here when I got to know him. He was these were the old days when they flew DC-10s to Thailand. And Chris would get that bulkhead set of seats back then because there wasn't that many people traveling in the early 90s. And he would lay on the floor. And the flight attendants let you do that. Now if you tried to do that, it would not be a happening thing. But that's how we met, going back and forth to Thailand. He was working in Chiang Mai, and we were working in Chiang Mai and Bangkok, and it was a really great time. That was when we used to put our specimens in our luggage in the overhead. Didn't always have the consent form. But we've learned how to do things perfectly now, and we've all gotten much better at all of this. So thank you, and it's a real privilege to be here. And I'm going to go pretty fast, so buckle your seatbelts, and we're going to go through some stuff really quickly. So just to, you all know this is where the epidemic looks today. This is a cartogram. The reason I show this, and I know you know this was the White House graphic of the week, so we're very proud of this. The White House does have a graphic every week that it selects from all of the programs, but this just, by the darkness of the green, is the prevalence, the size of the country, the burden of disease. So 72% of the entire epidemic is in sub-Saharan Africa, much more in southern Africa, but you can see Thailand and you can see Brazil and some of the other high burden countries. The largest, which you don't see here, is the largest burden of disease in Eastern Europe and Central Asia is actually in Russia, who more than likely most times does not report, but accounts for 85% of all the new infections in that area. So the Ukraine counts for the other 8%. So there are places on the map not completely or proportionally represented because of their lack of reporting. About 2 years ago now, UNAIDS wrote a document called the Fast Track Strategy that said that we were headed to 2.5 million new infections a year. We're currently at 2. This was really unnerving for me personally, running this program that was supposed to be having this tremendous impact. And I couldn't understand how we had dropped incidence by 50% and how we were headed to a historic high of new infections and almost 100 million infections by 2030. And when you dissect underneath this, it is because of the youth bulge and the youth wave that is in sub-Saharan Africa. So there's 50% more young women between 15 and 24 than has ever historically been or will ever be in the future, particularly in southern Africa where they have a truly youth bulge because their fertility rates have dropped. But the youth wave throughout the rest of sub-Saharan Africa continues until 2050. So when you've done this incredible job that the world was part of in improving under 5 survival, and now those under 5 children are 15 and at high risk for HIV. So in this document, they laid out how we could get to 200,000 new infections a year, and that really captured our imagination. But what they said is this 5-year period between 2015 and 2020 was the core period because of the number of new young women at risk for HIV. So even though we had decreased incidence by 40% because we had 50% more, we were going to go to this huge expanded burden of disease. Well, we're not on this blue line yet. We're right here. We're at 2 million new infections a year. So we have some really incredible work to do together. And this is a time where this is the budget that we oversee. It's about $6 billion a year. This is our global fund contribution. And this is the bilateral program. That's the program that the United States directly funds in a whole series of countries. So we have less money than we had in 2011, and this real need for investment in prevention, as well as treating those who are already infected. We also have been really working on what the definition of sustainability means, and we have come to the conclusion that you can't talk about sustainability until you control the epidemic, because an ever-expanding epidemic and the cost of that epidemic continuing to expand will not be sustainable. Even if today we doubled the investment that low-income countries had in health, and HIV specifically, it would only account for 9% of the resources needed. So we really have to see how we can take the money we have and make it more effective. So we coined this phrase, hoping it would also capture people's imagination, talking about the right things in the right places, in the right way, and right now. We used to say right time, but those of you who may know me, I'm a little bit impatient, so we now moved it to right now. The great news is, at least in HIV/AIDS and in malaria, we know precisely what the right things are. Due to the work of many people here, have really done the critical studies that really showed what we need to do to control this epidemic. So we know treatment is important because treatment lowers community viral load and decreases transmission. And then we developed 2 strategies to address this youth bulge and youth wave. One, circumcision and PrEP for young men and key populations. And then for young women, a strategy called DREAMS, which stands for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young Women. Recognizing it needs to be a multi-sectoral approach in order to deal with what puts young women at risk. Now, the right places discussion has been more difficult because there was really a misunderstanding between equity versus equal. And so we had taken a very equal approach where we worked in the same way and invested in the same way, independent of the burden of disease. And now we're taking a very equity approach, investing by burden of disease itself, so that we're investing according to the need. And that has been difficult when you start moving money around between places where there isn't HIV to places where there is a lot of HIV. We had this very problem in the United States when we moved money from Wyoming to Oakland. Wyoming was very upset. Oakland never said thank you. So this is what happens when you move public health money around. So it's difficult. The other thing is we moved our data collection all the way down to the site level and started analyzing information at the site level. And that's really allowing us to see what kind of quality services are we providing, what the cost of those services are, and whether we're actually having the impact we wanted to have. And hopefully you got a sense of urgency, because if we don't figure out how to get on that blue line, in this phase of level funding, both in the Global Fund, PEPFAR, and host countries' ability to pay, we will far outstrip our ability to treat. And we're talking about then in 5 years, people dying around the world from HIV/AIDS again. So we're really working very hard to get us into a different place. Now I'm just going to go through some challenges with you. The teams come in now twice a year. We meet with them in quite extensive detail, using data as our fundamental analytic tool and using data down to the site level. So one of our challenges was low testing yield and reaching the populations that are at the highest risk for disease and for highest risk of transmission. So if you look, last year we funded 68 million tests, but we directly funded 48 million. That means we either bought the commodity or we paid for the individuals that were doing the tests in the clinic. And we tested 48 million people. We found nearly 2 million positives, which left a prevalence of 4%. Now, if you're used to the United States, you probably think, oh, well, that's great. But we work in the highest burden countries of the world, where this would be the lowest countries' prevalence almost that we work in. And in the lower burden countries, we do key population work, either in people who inject drugs, sex workers, or men who have sex with men who also have a higher prevalence. So this number is woefully low compared to the prevalence that we should have. So what's that prevalence should look like? This is the prevalence of gay men across Asia and the Pacific. Here's Thailand over here. I highlighted it because of recognizing Chris Byers' long-term work there. And you can see that the prevalence is around 10%. So when you get a prevalence of 4, you've got to realize that you're testing in low-risk populations. And this is the prevalence in sex workers in the same area. And I wanted you to kind of get an idea of how great the MSM prevalence is compared to sex workers. And then, of course, the incredible high risk of prevalence among people who inject drugs in the same area, with prevalence about 20%. So we also wanted to dissect out, where is the issue? Where are we finding people and losing them? Or are we never finding people? So this is what we call the clinical cascade, one from Thailand, one from Laos. And you can see that this is the estimate number of MSM, HIV positive MSM. And these are the number on treatment. These are the number diagnosed. It looks very similar in Thailand. So we're not finding them to put them on treatment. So our problem is our testing strategy. The problem is not, once they get on treatment, staying on treatment or being virally suppressed. So this is really helpful because it tells the teams the facilities are doing well, the clients are adherent, but we're not finding them, so we don't have the right testing strategy. Well, the great thing about what data does, and the data is missing on this slide, but I will tell you what it is because I have it memorized. It was dogma in global health, if you were dealing with high-risk and vulnerable populations, that the best way to reach them was through paid community outreach supporters. That you would give funding to get into the network, find individuals who are HIV positive, and bring them into the clinic and be navigators for the patients. Well, we tried something new in Thailand because the rate here, you can see, was about 4%, the prevalence that they found. They tried something new. They found individuals who were actually in the network and of the network and paid them in cell phone minutes based on the number of positives they referred. They didn't know if the person that they referred was positive or not. But in this way, those in the networks that were in the highest risk networks who referred the patients most commonly received the most cell phone minutes. And their prevalence that they found was 12%. So we have switched all of our work into this peer referral network system. So this dogma of this being the best, I love the term best practices. Not really. Because best practices became something that someone wrote up, reported at a meeting, but there was never any comparator. So now we require, if you're going to say something is a best practice, you have to compare it to something. So this is a little bit like when you do effectiveness studies. You know, you have a practice that you think is great and it has to be as good as that practice before you switch to that drug. So this is the kind of effectiveness studies now that we're requiring of all of our teams as they do these kind of work in the field. The other big challenge that we have is we haven't impacted adult new infections. Despite the investment that you heard about, the U.S. government has invested $70 billion in HIV/AIDS. TB, and malaria. And we haven't infected new infections in adults. These are the PEPFAR countries in Africa where the highest burden is. And this is pediatric new infections. And you can see across the board we've had tremendous impact in preventing new pediatric infections. All the countries are more than 50%, except for Nigeria and DRC. But in general, huge impact pediatric infections. These are adult new infections. We've actually had, and I see Ron is here, 100% increase in new adult infections in Uganda. And these are the rest of the data. So these are the kinds of issues, this is UNAIDS data. But you can see there's only 4 countries over there that have had the same impact in preventing new adult infections over the same time period as they did in pediatrics. So again, we go back to very disaggregated data and try to understand what are we doing wrong? Well, now we talked about one of our pillars is treatment. This is the clinical cascade for Kenya as of today. So this is data from 2015. These are the number of women that are living with HIV/AIDS, and these are the number that we've diagnosed. Now, about 3 years ago, PEPFAR supported the rollout of what we call B+. So 100% of pregnant women who are HIV positive are started immediately on treatment. And you can see their clinical cascade, 72% are already on treatment. Now, we had this perception that the problem with men was we were diagnosing them, we were getting them in care, but they were defaulting. But actually, it's not true. We just had that negative perception. It was not a correct perception because the real problem is getting them in and getting them tested, because once they're on treatment, they stay on treatment in exactly the same way as women are staying on treatment. So again, this utilizing and constant utilization of data is really changing how we look at programs and how we decide what to invest in. So now we know the problem is not testing in women, it's finding men, getting them diagnosed and getting them linked, because when they link, they'll stay in. So this is Swaziland, smaller country but very high prevalence. This is the male cascade. Now we look very carefully to ensure that our targets are going to be part of the solution that UNAIDS has laid out in their strategy. So within the end of this year, the purple bars will be achieved. And the end of next year, the blue bars will be achieved. So we analyze our data continually for how we're making progress on the core interventions that were believed to control HIV. But you can see by the end of next year, women will be way past what the UNAIDS determines as 90-90-90. That's 90% of the individuals diagnosed, 90% on treatment, 90% virally suppressed. So women will be at about 93, 95, 95. But men, we're still having a little bit more work to do. And you can see how many more men we have to diagnose over the next 12 to 18 months in order to get them to the same rate as women. So these are done at the national level, the regional level, and the district level, so that every district can know how they're performing in real time, and it's done quarterly so that we can make mid-course corrections. And this is Zimbabwe's. So same issue, once men are on treatment, they adhere in the same way. They're just diagnosed less frequently. Now we also have, and I didn't want to make a lot of confusing slides, so for all of you. So this is how the data is looked at. This is the data by every single district, male and female. And it's also age disaggregated, but I put all the ages together. These are adults over 15. And this looks at what our coverage is. So you can see it's not equal. This is the highest burden area in Namibia, and our coverage is the poorest. So it really tells us how we should focus our resources, where they should be, and what we should be doing. Now, I talked about this dramatic increase in infections in adolescents and young girls, and that's by burden of disease, not by incidence. So incidence rates have gone down by about 15%, but because there's 50% more women, young women, you can see that the burden of disease continues to rise. Now, fortunately, the World Bank is finally going to write a piece on this. I've been really pushing them on writing about this youth bulge, because these were the Millennium Development Goals. This is what we committed to in 2000. But when you think about this goal 4, which was to reduce childhood mortality through improvement of immunizations, through treatment of malaria of PMI and Global Fund, the President's Malaria Initiative and the Global Fund, and through HIV work, decreasing mother-to-child transmission. This was widely successful. In fact, there are 75% more under 5 surviving today than there were in 2000. But no one planned for what you were going to do when they were 12 and needed to be going into middle and secondary school. Or if you're an adolescent young girl, where are you going to get your health care? Because the healthcare system was all based on reducing childhood mortality and improving maternal health. So the focus was really in sub-Saharan Africa and in resource-limited settings in the maternal child health block. But if you are older than 5, if you're 15, or you're non-pregnant and you're a male, there wasn't a real place where you got wellness treatment, where you got diagnosed for chronic diseases like HIV or others, and then received wellness and prevention interventions to prevent disease. So this is PEPFAR supported these Millennium Development Goals. And so it was really quite successful. This is South Africa at the beginning of the epidemic. The pink are the girls between 10 and 29. There were 7 million, now there's 10 million. Now in South Africa, it's truly a youth bulge because South Africa, Namibia, Botswana, this is their fertility rates. So you see by 2050 that bulge has moved through, and now they're the millennial equivalent. So it's really for South Africa, Botswana, and Namibia, it's really an acute issue right now, which will become less of an issue. For the rest of sub-Saharan Africa, it's this orange bar is the fertility rates, which remain high out to 2050. And you can see that this is a youth wave that continues unrelenting. So in 1950, we had 25 million 10 to 24-year-old females. We now, by 2050, will have 300 million. So these are the kinds of numbers that you have to understand when you're doing public health to prevent something. Because you really have to know how big is the group that you got to do prevention interventions with, and where do they live. So because of this, we launched Dreams for Young Women. Young women account for 71% of the infections in adolescents, and it's about 1,000 infections per day. We launched it in last World AIDS Day, and we had very aggressive goals. And some people will think that they're quite aspirational. 25% decline by the next 12 months, and a 40% decline in incidence over the next 2 years, which are quite aggressive. But that was the minimum to prevent expansion of disease burden. So this was the minimum, even though it sounds like it's quite aggressive. We put a significant amount of money in it. It became a public-private partnership with the Bill and Melinda Gates Foundation, Girl Effect, Johnson & Johnson, V Healthcare, and Gilead. Almost $400 million investment, and we just launched an Innovative Challenge grant, and we'll be announcing those winners at IAS, we hope. We had over 800 applications for the $85 million. These are the DREAMS countries shown in orange, and again, those are the highest burden countries with the highest number of adolescents and the most that are at risk. Now, we have never attempted to do something like this before because it's an integrated strategy that's multi-sectorial, looking at how we work with young women to empower them to a different place in their lives and a different future of remaining HIV negative, how we work with communities to decrease gender-based violence, which accounts 35 to 40% of the first sexual experience for young girls is coerced or frank rape, and how do we work with communities to value young women, and then how do we work with the family to ensure young girls stay in school. We put a small amount of money in finding men and getting them on treatment, and then we added another outside of the DREAMS funding, another $150 million focused on this issue, because here are in every DREAMS country, the men who are on treatment versus the women who are on treatment. So we know we have work to do there, and we've invested a significant amount there. But I want to bring you back to the United States, because the exciting thing about the program is we get to work between the global and the domestic, because many of the institutions like Johns Hopkins works in their area domestically and also works globally. So you've been doing this all the time. We're trying to bring that to PEPFAR to really understand what can we share about learned lessons from work that we're doing globally that could work in the United States, and what can we learn from the United States. So if you look at prevalence in South LA, we were just there a couple of months ago, and you look at completion rates of high school, the light purple is the lowest completion rate, and you can see that it overlaps with HIV prevalence. And the epidemic in the United States has very much changed from a gay white male epidemic into a young man of color epidemic, particularly in vulnerable areas. And you can see prevalence linked to less high school education. Same work done in Botswana, where they added 1 year of high school education about a decade ago, and then they followed those individuals, both the ones who received 9 years of education versus 10 years of free education. When they looked at age 32, a third less HIV in just that 1 year of additional education and keeping you in school. And if you looked at girls, it was 50% less. So we're very much focused on this, keeping girls in school, ensuring that they have an opportunity to stay in school, but ensuring that they're safe while they're walking to school, and that they're safe when they walk home from school, and that they're safe while they're in school, and they're not being raped by their teachers or another individual who's in the school. And part of this is really a wraparound program that as we work with countries to improve access for young girls into schools, we're also working with countries to ensure that there's health education, sexual education, and access to core reproductive health commodities for the young girls in a way that is not stigmatizing and discriminatory for the young girls who need this. So the DREAMS initiative is now launched, and we're evaluating it. There were 6 areas, primarily keeping girls in school, finding new ways to find men, talking about PrEP, that's pre-exposure prophylaxis, that's giving it to high-risk girls, particularly adolescent girls that are particularly high risk, and following them over time. Leveraging community capacity to really increase and value young women and giving them voice. And then this issue of a secondary school bridge to employment. Employment rates in most of sub-Saharan Africa for young people is between 40 and 60%, and that's the way it is now. Remember, I told you there's a youth wave, so those unemployment rates could go to 75 and 80%. So we announced very bold targets, and I'm going to go through those and a little bit of the results. So our targets were announced by President Obama at that interface between the completion of the Millennium Development Goals and the start of the Sustainable Development Goals, to really announce to the world that the United States is committed to ending HIV, TB, and malaria as noted in the Sustainable Development Goals, and took that opportunity to announce these 3 targets. And it's the first time we've had 2 prevention targets and 1 treatment targets, recognizing our increased investment in prevention and recognizing the need to create the AIDS-free generation that President Obama announced and is committed to from 2011. So 13 million circumcisions by the end of 2017, a 40% reduction in incidence of new infections in young women, and nearly 13 million on treatment. So where are we? We have almost 9 million circumcisions completed. We do all these analyses by country so we can look at country performance. But we also look at this age banding, this question, because remember I talked to you about level resources. So one of the ways to have an increased impact on your population at risk is the focus on the population that's immediate risk, and that's the orange bands. And that's the 15 to 29-year-old young men. And you can see that we're still circumcising a lot of people under 15 and not doing quite as well with that age band that we should be focused on. And then we map this down to the site. So this is just what it looks like in South Africa. These are our focus areas that have the highest burden of disease. And we look at these dots, the darker the purple, the bigger the circle, the number of circumcisions that are being done. So you can see where they're being done and how effective they're being done. And then we look at the financing at that site so we can see if they're performing at the level that's commensurate with our investment. Now, Test and Start is a new WHO guideline, and we find this very exciting because for the last 12 years of PEPFAR and the Global Fund, we've been saying to men, which is part of our issue and our problem, that their CD4s were too high, so they didn't need anything. And then they didn't come back until they were very sick and dying of HIV. So the women we had B+ for. The men, we said, unless your CD4 was less than 350 or less than 500. Now that became a very confusing message. And I think it was confusing to the ministries of health also, because it kind of said, you have to get really sick and get sick to a point where we can't reverse the immunologic damage that has been done. And your lifespan is shortened anyway, and then we will treat you. So what the WHO said is we're doing away with that. We have one message. If you have HIV, it's causing damage, you need to be on treatment. And that unifies and creates a very simple public health message, because it was difficult to say to a man, your wife is getting treatment, but you're not. And that became a real misunderstanding about, well, is it less transmittable if I'm a man? And that's why they're not treating me. So now we have one message. So last year, as I mentioned, we tested 68 million people, 45 million directly, but we weren't actually performing at the level we needed to perform at, the 9.5 million on treatment. And then I'd say, well, what does the retention look like? And we've broken down every country by greater than 80% retention. These are all the PEPFAR countries, 70 to 79 and less than 70% retention. So we know where to focus our resources. We've been rolling out what we call viral load. That's monitoring for the level of the virus in the blood, because obviously once you're on treatment, the level of the virus in the blood should go to undetectable if the treatment is being effective and you're going to prevent progression of disease. It also makes that individual less transmittable. So these are really core pieces. But this fact of these new WHO guidelines, which said that you should test and start people immediately and use alternative service delivery, and I'll talk about what I mean by that, caught our imagination with how could we today double the number of people PEPFAR is supporting on treatment, and what would that look like? So we did this analysis. So in the blue bars, in every country, people are being followed at less than 3 months intervals of frequency. That's a lot of out-of-pocket expenses for them, and a lot of out-of-pocket expenses, a lot of resources in the medical clinic seeing them. So this is how much it costs to see one patient. This is the cost savings across. This is what it would cost to see that patient every 6 months instead of every 3 months. And these are the cost savings. And you can see we're starting to get close now to the cost of a single client seen every 6 months. The cost that we could add a second client. So now we can immediately increase the number of people on treatment by 75% if we move patients to being seen every 6 months. And that has been shown to be just as effective in stable patients. More importantly, it starts moving towards a wellness model that we can utilize in creating a health system for the 21st century in sub-Saharan Africa that could deal with hypertension, diabetes, and other issues related to wellness. No one who has diabetes and stable is going to be able to come to the clinic monthly and pick up medicine and be seen. There's not enough human capacity to ever do that. So by using HIV/AIDS, we can start really creating a system of wellness that can be applied to any chronic disease. Right now, all these yellow countries require clients to pick up their medication every 2 months. The red country, monthly. The red country has the worst retention in all of sub-Saharan Africa because you can't afford to come back monthly, lose a day of work, stand in line just to get a refill. So these are the kinds of things we're tackling, not only for HIV, but we think they'll have huge implications for other chronic diseases. So when we talk about shared responsibility, which historically had been talked about as co-financing, shared responsibility is what you are going to contribute. But actually contributing this policy change and going to every 3 to 6 months of follow-up actually creates the window of opportunity to do so much more with your current dollars. So we've been working with countries on this policy change because we think that's the most effective way to actually decrease the number of new infections by 50% in the next 5 years and decrease the amount of AIDS deaths by 50%. And that's what this looks like. And now we start looking like the strategy of UNAIDS. And that was our benchmark, and that's what we were trying to get to. And this gets us very close on the blue line to about 800,000 new infections a year, way down from the 2 million we have right now. Importantly, this is a model from Botswana. If you treat people immediately, you decrease the number of TB cases by over 60,000 with a $33 million savings. So this is not only about ending the HIV epidemic as we know it and as a public health threat. This would end the TB epidemic as we know it, because 75% of it in sub-Saharan Africa is driven by co-infection with TB/HIV. We've done a lot of work in PMTCT, and we just talked about a lot of challenges and how we were focusing and aligning. These are the number of women who were tested last year for HIV through our PMTCT program, nearly 15 million. Almost 1 million mothers newly diagnosed and put on treatment. But again, so this is where we hoped we would be right now at 33,000. We're at 173,000 in our global plan countries that we were focused on, and a lot of it is due to Nigeria and the lack of progress in Nigeria, both in infections during pregnancy and infections during breastfeeding. So we haven't had the impact there that we have had in many other countries, despite the fact that we have equal investments in that country per person living with HIV/AIDS. And so this really shows that it's more than money. And you really need to have that combination of leadership. Interestingly enough, this looks at HIV prevalence and wealth incomes and median incomes. And you can see that the lower the median income, the higher the rates of HIV. So then you start looking in Nigeria about, well, maybe this is an issue of access to ANC, and you can see that the least wealthy have the least access to ANC because Nigeria charges fees in the ANC clinic, and it's not differential fees by income level. And that impact that it has is the least wealthy can't afford to deliver in the health center and therefore have the highest infant mortality and the lowest immunization rates. So again, a lot of the inequities that we see in this country that are driving certain diseases, we also see in Nigeria with HIV. Just a quick comment on pediatric, because pediatric treatment for HIV has lagged behind adult treatment, and we've been very much focused on that. I'm going to skip right to what we've done over the last 18 months. We announced that we would double the number of children in treatment in the highest burden countries, but what happened is we actually increased treatment everywhere because everyone became very much more focused on children. So when you talk about things, it increases people's awareness, and even though you weren't the focus, these are just the countries we focused in. In the first year, we increased the number of children on treatment by over almost 200,000. Our goal was 300,000 over 2 years. So we're well going to eclipse that. But the entire program now has almost 800,000 children on treatment because of this focus. And we've tested twice as many children last year. I'm going to go quickly through the right places discussion so that we can have a discussion and you can ask some questions. So this mapping of disease has been happening in HIV for decades in the United States. This is prevalence and incidence mapped by zip code. So we've been just applying that same kind of granularity at the lowest unit of disease that we know by district in Uganda, but we've done it in every single country. And we've mapped 100% of our sites. So these are the PEPFAR sites that we support in Uganda. This has really helped us to know where our money is, know where the infection is, know the population we need to reach, and really understand what we're doing in a much more granular way. And then we look at testing. This is just routine counseling and testing, not testing in ANC, not testing pregnant women. This is just routine testing. These are the highest burden areas. And you can see there's some yellow, light yellow. Light yellow means that you have less than 1% positive tests. So when we see that in a really high burden area, we start to ask, is there stigma discrimination there? Is there lack of access? What is the real reason? Or is the fact that we just have less burden in that pocket of that district compared to the rest of the district? We also map all of these sites for how they're performing in treatment and how many women and men they have on treatment and what the coverage is of that treatment. So in the green, it shows the coverage. The blue is the total need. So just at a glance, you can immediately tell how the country is performing and how each site is performing. And are we getting close to meeting the need of the population in that area? We've been working very hard on how to translate Excel spreadsheets into something that's actionable. And so we've really been doing a lot with GIS and mappers to try to really translate Excel spreadsheet data into something that's visible and people can really understand how they're performing. This is our Orphans and Vulnerable Children's program, and these are the DREAMS districts. So the DREAMS districts in Uganda are in the highest burden, highest prevalent areas where the most transmission is occurring. And then these are the circumcision sites, just looking at the first quarter and over the last year. So we can really look at performance quarter by quarter. Now, quickly to take you through Rwanda, to just let you know that that 90-90-90 that the UNAIDS talked about, 90% diagnosed, 90% on treatment, and 90% virally suppressed, this is where Uganda was last year in achieving those goals. And this is the map that shows saturation of above 90%. So you can see a lot of districts are already saturated. This is where they'll be at the end of this fiscal year. The US government's fiscal year will end in September 30th. And this is where they will be, and they'll be very close to the entire cascade. And this is how the coverage looks by map. And then this is next year, about 18 months from now, and they well exceed the 90-90-90, and the entire country is covered except for one district. And this is their viral load coverage. Now, we would like every country to look like this. This is our best viral load coverage in all of sub-Saharan Africa, where the least covered district is over 60%. Now, if we had that in the United States, where you could say the least covered area had 67 or so percent of their individuals knew their status and were virally suppressed, it would be incredible. Now, I know you have a lot groups that work in Zambia, so I wanted to show that very quickly. This is burden in Zambia by district. So the darker the area, the higher burden of the disease. These are how well our coverage has been. This is how well our coverage will be by this September, and how well it will be just 12 months from now. So this is giving tools to teams to really see if they're succeeding in the goals that were set out by UNAIDS and then signed on by countries as far as this fast track document. And by the end of next year, they will have 77% national coverage. And so these things are all possible when you really focus and continue to look at outcomes. I'm going to end with Haiti because when we started mapping carefully, we mapped all of Haiti, again, darker, more HIV burden of disease. We found this whole area up here of very high burden of disease where there were no services. So if you looked at services, you'll see it's very white, no matter what service you were looking at. This was a real wake-up call to the government. It was a wake-up call for PEPFAR, and we just hadn't gotten there. Port-au-Prince is down here. This requires them going all the way around, and we just hadn't. So this has allowed us to really find the pockets of the underserved area. And so I'm not going to go through these pieces because I know we're short on time. We do spend a lot of time building local capacity. This just looks at CDC investment, and you see they receive about $1 billion a year in PEPFAR money, and the majority of the money is shown in the blue bars now goes strictly to indigenous organizations. So more than 60% of our funds that go through CDC go to local indigenous organizations to deliver services, whether it's prevention, care, or treatment. And finally, civil society. This community work and civil society work is critically important to us so that people really understand who their key populations are. Have they been mapped? Do we understand in the same way that I just presented general epidemics, do we know those same details for key populations, whether it's men who have sex with men, whether it's people who inject drugs, or whether it's those engaged in sex work and transgender people, which we know are at higher risk of HIV, but do we know where they are? Do we know that we're reaching them with interventions? Do we know we're reaching them with prevention services? Are we seeing a decline in incidence? Are we sure that we're serving them in a human rights-based approach? Well, we're not, and it's coming from us as healthcare workers. So in Jamaica, FHI 360 did this really dramatic study. They asked, and I really applaud that the healthcare workers honestly answered this material. So they went into public clinics in Jamaica because the clients were complaining across Jamaica that they were being discriminated against if they had HIV, and doubly discriminated against if they were HIV in a sex worker or HIV in a man who has sex with men. And you can see that they have refused healthcare services. They disclosed the status and gossiped about the patient. Now, when you're on an island and someone's disclosing your status, this is extraordinarily difficult. That they HIV tested without their consent or didn't give them their results, that they signed a junior provider to the case because the senior provider did not want to see the individual, and that they received less care than other individuals in Jamaica. And I think this was a real eye-opening for us too. So over the last 12 months, we've completed a sexual and diversity training for all of our staff, no matter where they are in the world. If you're a Ugandan or you're a Kenyan or you're a Cameroonian and you work for the US government on HIV/AIDS, you've had this training. And that was really incredibly important, that people understood key populations, their unique needs, how to speak without embarrassment, how to speak with reinforcement, how to speak in a voice that allowed people to come to a health system and be received with open arms. And that's been a lot of our focus. So I'll just end by our increased investment in community and civil society, because this costs money to build that empowerment, that advocacy. We put $10 million in the Robert Carr Foundation. That's focused on regional and international advocacy and training. Put additional $4 million in a faith-based initiative to really understand, are the churches engaged? And how are the churches dealing with communities where we know 30 and 40% of the girls' first sexual experience is gender-based violence? And how are we dealing with that as a cultural issue, as a community issue, and giving those young girls a space to receive information and to actually receive care? And then additional money into the Elton John AIDS Foundation together to really fund anti-stigma and discrimination campaigns. So that these are the Sustainable Development Goals. I'm sure you have them memorized completely. And they're, for the first time, every country is equal in the Sustainable Development Goals, because they're goals for all of us. This is where PEPFAR works. We work in poverty reduction because of our work in young women and communities. Our work in number 3, which is good health. Our work in quality education to improve access for young girls. Gender equality and dealing with gender-based violence and other issues that disempower young women. Good jobs and economic growth that come through health. And decreasing and reduce inequities related to independent of race, independent of sexual orientation, to ensure that our services are available. And then making communities stronger with the work that we're doing at the community level, and certainly the partnerships. So I know you work in all of these areas, the work that you do. I love the slogan, saving millions of lives in the last 100 years. Thank you for your work there and the work that you continue to do. The one thing that we have that is very concerning is when people started talking about the end of AIDS, people thought it was over. Because why would you talk about it at the end of it if it wasn't really on the... But instead, what's really the problem, because of the youth bulge, we have a moral obligation to do more and prevent more new infections than we ever have since the beginning of the pandemic. So at the time when we were talking about the potential of changing the course of HIV/AIDS, we have new and more dramatic issues. We've had this week, while we're all here, we have 35,000 new infections in adult and over 7,000 in young women. So we still have a significant amount of work together, But I'm so confident, and every time that we have worked together, and certainly Johns Hopkins is a huge implementing partner of PEPFAR, every time we have focused and worked together, we've had dramatic and impressive results. From the very beginning, when President Bush said we were going to go from 50,000 people on treatment to 2 million, that was daunting. When they announced that we were going to go to 4.5 million circumcision and we are doing less than 500,000 a year, that was daunting. So when people say, how are you going to face this youth bulge and 30 or 40% more young women and young boys and young men are going to be at risk, I say we've done this before. It may be more difficult, but when we join together in a unique way, when we translate science into compassionate programs that are based on justice and human rights, we can have amazing success together. So thank you. I'll end there so we can take about 7 or 8 minutes of questions. Yes, these are all my colleagues going back to the last 30 years. We're not aging at all. No. We're just getting better.
That was fabulous. It really was. I was interested in the slide you showed about perinatal transmission.
The one with breastfeeding?
And the very large component of breastfeeding. And what is happening there? Am I misinterpreting it?
No, you're absolutely correct. And I think that was really what drove all of our interest in B+. But remember, unfortunately,
this was before.
Yes, and it's 2015 reported data, so it was collected in 2014. So it was just in the first year of B+. So you can see Botswana and South Africa that had extraordinary programs. They were under the 5%. The B+ issue, now remember, we told women that they were getting treatment to protect their baby from getting infected during pregnancy, during delivery, and during breastfeeding. Now we can tell them it's for your own health. Because I think you'll get a very different level of adherence, and some of these light blue bars may reflect adherence to B+. Because we really couldn't tell the moms we were doing it for them. And now we can. Yes. Yes and this. And then we'll go over here.
Thank you for the presentation. I'm curious, it strikes me that a couple of the things you're talking about, for example, Dreams, that's looking at the integration of school-based efforts to keep young women in safe places and in school and reducing transmission, as well as the other areas, require integration across government ministries in a time when funding is more challenging and the ministries of health are adapting from having had very independent funding streams to work in this area, are now having to share funds with other ministries and other partners. Similarly, within the health system, if we're going to test and start, it's going to require efforts across different health departments, across the outpatient units, as well as any HIV-specific services, and similarly asking them to engage with young people in a way that they haven't necessarily before. So these are all areas which require integration, and integration which may be challenging. I'm wondering what PEPFAR is doing, if anything, to sort of support at that macro level this new integrated approach, which is a challenging thing that takes time.
Exactly. You just laid out all of our challenges in Dreams, and I think that's why we really focused Dreams in a limited number of districts where the transmission was the highest, because that kind of discussion that you described takes an either enormous amount of time or a level of intensity that is very deliberative. So we've taken a very deliberative and intense approach to this, to work within the communities so that the communities are aware, the chiefs are aware, the school teachers are aware, the district health officer is aware, the district managers are aware, because it really does what you just described. And I think we have hope for this. We also have hope about this health center for the health system for the 21st century, because when people have told us to integrate into the health systems, we're like, yes, we've done that. That was the maternal child health block. Now we have to create new spaces and a new and really cultural environment where people utilize their health center to receive wellness messages and disease prevention rather than acute care. And this is a huge shift in thinking in how we work. But if we want to deal with non-communicable diseases, we have to get there. And we have to get there together. The other thing that I did mention, at the same time, Africa is urbanizing. So we had brick and mortar everywhere. We may not be able to afford brick and mortar in really low population centers. We may have to move to technology of mobile vans with text messaging, where there is a certainty that people will be there on Tuesday, but can also respond to emergencies, where a nurse can cover a whole district rather than having 15 health centers in a district, all of which are under-resourced. So trying to figure out how we use the resources in a new way. And the reason we're quite excited and hopeful is because Africa leapfrogged in telecom. So if they had waited for the wires to come to the village, they would have never had phone coverage. But they went to cell phones. So can we leapfrog into a 21st century health system that really meets the needs? Yes.
Actually, my question is related, and you started to answer it around one of the challenges with meeting these rather ambitious targets, in particular 99-90 combination with the test and start, is that you're going to have a great number of patients you're starting to see in a short period of time. So what is your sense about the absorptive capacity of the health system that you're working in to be able to take this on? And in particular, what is PEPFAR's role in doing health system strengthening to try to improve, to create that health center that can help with other chronic diseases, not just HIV?
Great question. So we have $750 million a year in health system work. So we've done, I think, a great job on the laboratory and really creating the opportunity for tiered laboratories, but we haven't taken that same deliberative approach at the health center. And at the district, creating that referral system that serves people where they are, but also have access to a next tier level if needed. The only solution we have right now, if you can think of other ones, that would be great, is moving to, instead of seeing patients every 1 to 2 months, to 3 and 6 months, because that immediately decongests, because you can see twice as many patients in half the amount of time. The good news is, in that numbers that I showed you, you can see that coverage is actually quite high. So we're really talking about needing to reach like a third more in most of the PEPFAR countries. The reason we have 35 million people infected, they're not all in PEPFAR countries. That's why I started out with the Russia issue. They're in other countries where we aren't, the Global Fund isn't, and frankly, the government isn't, the government of Russia. So that is still a huge divide where people in Russia do not have access to treatment in the same way that people in China do. And so we will continue to have that gap between what we're able to do as a global community versus what is really needed because of that leadership issue when it comes to HIV/AIDS. I wanted to go over here, yes sir, and then back here, and then over here.
You were mentioning how data is driving a lot of investments and all the way to site level monitoring. And I was wondering, I was curious about PEPFAR's site level monitoring system, SIMS, and I was wondering if you could comment on how that's going and will it continue?
Great. Let me take the question in the back too, so we can get to this last question over here. Yes.
Oh, great. Thank you for the excellent talk. I was wondering about the role of pre-exposure prophylaxis.
Great. And over here.
Hi, thanks for the talk. The government's role in high-burden areas are to serve all of the population. So PEPFAR came in these high-burden countries and said, we need to go to the high-burden areas in your country. I'm wondering first how the countries responded to that, and secondly, whether they've been able to take up the slack in the areas, not slack, take up the areas where there still is infection and the potential for growth in new infections, but you have to leave those be and focus on the other.
So great questions. SIMS is continuing. We've streamlined it. It was taking our staff about 6 hours per site. So we've streamlined it, we hope, down to closer to 2 hours per site. And we're looking at that data very carefully. And the great thing is we're seeing improvements proactively in the clinics that we haven't gone to as people start communicating between clinics about quality improvement. So PrEP, pre-exposure prophylaxis, is within DREAMS. It's also one of the WHO guidelines recommendations, and we're supporting it within key populations. PrEP within general populations, we haven't moved to yet. A lot of countries want to see how the DREAMS piece goes first in reaching young women and key populations as we move forward and have this broader discussion. What we really need is long-acting ART. It would be the biggest game changer on the planet to have it. And the question of geographic focusing. This is one of the most difficult questions because obviously we would want to be everywhere for everyone. That's the point of what PEPFAR is grounded in and what we remain committed to. What had happened is because we were equal in investment, if you were in a low burden area, your coverage was about 100%. In fact, often it was 105% because people came across the border, or because a lot of these low burden areas are very remote. And so if you lived in northeast Kenya, you all had access to treatment. If you lived in Kisumu, where your prevalence is 5 to 10 times what it is in northeast, your coverage of services was about 20%. So this isn't about decreasing the coverage in the low burden areas. This is about increasing the coverage in the high burden areas. And that's been a very difficult concept. We are working with countries to see if they will pick up the low number of patients in these low burden areas, because in the long run, all of these programs have to transfer over to country leadership and country implementation. So we've given countries additional money to do that directly themselves, to see what that looks like. But we're monitoring that very closely because a core tenet of PEPFAR is we don't withdraw services. It doesn't matter if you're an orphan and vulnerable child and receiving comprehensive services there, or you're receiving prevention services, or you're receiving treatment. We don't withdraw services. So this is really a very big question about how much and how fast we can move. And it's open to discussion because we haven't really moved yet from any site, but we're slowly trying to figure this out of how we can get the high burden counties up while maintaining support to the low burden regions. And we will have to come up with some innovative ways to reach and maintain, particularly as Africa continues to urbanize. Because then you're talking about really extraordinarily low population areas where there's a lot of migrant movement, not migrant in the sense of migrant moving through the country, but more migratory behaviors of different groups and different tribes. So thank you.
Wow.
Thank you. Thank you for taking time out of your day. It's great to see everyone.